comment you just made, Adam, puzzles me because I've gotten information from those who I feel to be knowledgeable on the topic that they do have the capacity to do this. Maybe they have decided against it. But as far as acute crime, and I know law enforcement routinely transfers to behavioral health facilities.
That's pretty interesting. That's an interesting point to make.
But let me confirm on those resources. I'm a little bit flummoxed at this point because it makes our efforts a little bit more uphill. In that wouldn't be something that we can necessarily promote as an alternative for, the ED essentially black hole that some of these behavioral health patients get into. So
yeah. Okay, that's interesting. And so Tracy, you said that you had found something very parallel to what I found. What kind of items did you find or information?
Right, that unless it's a police officer serving a court order, EMS has to go to the ED first to get medical clearance before they can go to a mental health facility. At least that's what I was told by our EMS liaison here in the emergency department. So because we have Mind 24, which is an emergent urgent care, I guess, if you will, but they do assessments, they can change medicine, they hold patients while they wait for inpatient placement, and EMS is not allowed to bring patients there. They have to come here first. Or if they go there, they have to come here for medical clearance, and then we send them back.
Right, and that's the same thing was echoed to me. Is that well, I can actually share my let me share. I took just some notes.
I'm gonna I'm just gonna go on mute while you're doing that because I'm gonna reach out on a lifeline. It's unlikely this person could potentially talk with us, but maybe I can get a comment back. I'm gonna
sure, take it. Sounds good. Anyway, so this is what I found for our research notes. If you'd like to just generally kind of go through them, but it's no real substance there. The most interesting one is this one here at the bottom, where because I interviewed individual crews, individual medics, individual captains, individual transporting people, and they all kind of had something similar in terms of we can do it, we can do whatever we want, we can just it's not really what am I trying to say? They can bend the rules every now and then for a very particular case. If the family pleads in just such a way, if the stars are aligned, sometimes they have taken them directly to behavioral health. But this is inclusive of calling a medical director on the phone specifically for this. And so it's not a common practice. Let's see who.
And many times our medical directors say, take the patient to the ER first anyway, because if you take them to there, they're just going to transfer them back to us.
Yeah, and it's like a fear of making it longer, because if they go to behavioral health and they go to emergency, the ED, and then they come back to behavioral health. And so, oh, hey, Tyler, thanks for joining us, man. We were just getting going.
He's walking.
He's a busy guy.
Hey there.
Hey, Tyler, thanks for joining us. We're just getting going. Dale, were you able to find who?
I just reached out. So okay. Let's see if I get a text back.
Okay. So we were just kind of discussing some of these, just some notes there, but there's no real substance here. The big takeaway is that what we've been discussing. It's only on rare occasion when they decide to bend the rules that they can do something other than rigidly take them to an ER and then to a facility. I was under the impression Golden Ranch was still able to transport. This is when they were under a different medical director, and it shows you how long I've been out of the field, about 5 years. When they were oversaw by a medical director at Oro Valley Hospital, they had a order where they could go, but reaching some of the transport personnel is particularly difficult. That has been on the box long enough to make comment and remember this clearly enough to make comment on this system. And so it's a little too stale, or at least I haven't found the right person that can educate me about how they were able to do this. And I never even got the name of that medical director either. And so I'm kind of dead in the water there. Did anybody else come up with anything else more, more encouraging than that? Okay. Yeah. So I didn't really expect much to come out of it. So, I mean, my question to the group is then, where do we do we realign ourselves? What do we do? Because the original problem is that we have a backup in the ED of patients that shouldn't be there, and that's a very easy thing to understand. But it's simple to understand; it's just not easy. And so, I'm not sure. I don't want to say I'm not sure about the project overall, but what smaller bite can we take where we can have a measurable effect?
Again, I'm still of the mindset that, I mean, we offer education support and strategies for management in the field. I mean, PACE is an EMS advisory group. We know there's a problem in the ED. So what are those things that could happen in the pre-hospital environment to maybe be more selective on those ED transports? That being said, EMS agencies are reimbursed when they transport, right?
Mm-hmm.
They're not necessarily getting the reimbursement when they essentially ultimately leave scene or, there is some compensation for treat and refer. But so that in itself is an uphill battle. But if we want to alleviate those and work to alleviate those transports, I think our committee putting together an educational tool to direct the EMS agent in the field on how to assess and how to triage patients who could potentially be identified to remain at home with guardians or for guardian transport to behavioral health facilities.
Mm-hmm.
Not to dispute this inability for EMS to transport, but being said, the parents can surely transport directly to a behavioral health facility, and they do acute crisis intervention. Then it's incumbent upon that behavioral health facility staff to determine whether or not there's a need for medical clearance. And it's not uncommon that we'll have a patient who will present on their own to a behavioral health facility, and that patient is then transported to the ED for medical clearance.
Mm-hmm.
So that's not something we can necessarily affect, but is there a subset of patients who may not necessarily have to go to the emergency department in the middle of the night? And then could there be de-escalation and a safe disposition at home for the behavioral health facility, either at same time or next morning? So could we put together an educational tool for the pre-hospital personnel to better work through those different decisions, those alternative decisions?
Sure. I think that's totally reasonable. Maybe instead of trying to reinvent the wheel, we can just create education that allows people to, pre-hospital personnel to kind of use what's already there. And it's a really good idea. I think it's a good point. If we're talking about going to a behavioral health facility, we're talking about a person who is medically stable, at least in appearance, to the paramedic. And so I agree with you. Maybe we can, I don't want to say refuse that patient, but that's the language you use. Maybe we can refuse that patient in terms of they don't need to go. We go through that refusal process. And then, it's a good point, Dr. Ward. Maybe we can have them transported for us and we can circumvent this entire thing to the appropriate facility. And we did. I think we have started already making a slide set. That was the initial knee-jerk reaction to the behavioral health group. Let me see if I can find it really quick. That's one of the things I didn't pull up.
And does that, so here's maybe a silly question, but who can medically clear patients?
That might be a multi-layered answer, but to say medically cleared, you might have to define that a little bit better. But at a minimum, I think at a minimum, a paramedic, not an EMT, not a police officer. So at a minimum, a paramedic, I think, can be someone who can say this person is a candidate to go to a different facility.
Okay.
But I'm not sure. Maybe there might be a definition of medical clearance that I'm missing.
Okay.
Let me share this.
I'm cautiously optimistic. The gentleman I just texted, his name is, well, I'm trying to send him the invite. Let's see if he can join us. I apologize. My apologies.
Sure, no, that's fine.
I just sent him the invite, and it's the whole thing texted to him, so hopefully he can figure it out. And if he pops up, his name is Coy. He's a nurse practitioner down here. He actually, very interesting background. He's a nurse practitioner. He's a medical examiner at the Advocacy Center with me. And then he decided to go back into the fire academy, and he is a firefighter.
Oh, great.
I think he's a wealth of knowledge on the material. So he might be hopefully stepping in. To answer the question earlier, medical clearance, it's really the purview of the physician or the practitioner to make that decision, and it's a risk-based assessment. So does the psychiatrist, who is maybe not an internist or an emergency physician, feel comfortable in saying that this patient solely has behavioral health needs, and therefore I will assume care of this individual? The psychiatrists in general don't take a lot of risks when it comes to the concern of behavioral health. Take a lot of risk when they think there may be associated organic disease. Therefore, it's almost a safety net to say, well, let me have this other physician look at them, make sure that this thyroid level is not a problem or whatnot, and then I'll take care of them. So it's a risk assessment. That physician who receives, or that practitioner who receives the individual at the behavioral health facility, it's up to them. It's kind of their purview to decide whether they're going to assume care of the individual.
Right.
So if a patient presents on their own to a behavioral health facility, they may do an intake, identify tachycardia or high blood pressure, and say, no, I want you to go get your labs done before we take care of you.
Right.
And that's kind of the default and the reflex to it. So I don't think it's, in each individual facility may have a protocol or an algorithm that helps them make that decision. But ultimately, it boils down to the purview of the individual receiving caregiver.
Okay. All right. That helps us a little bit there. Okay. Tyler.
So I recall several years ago, there was a pilot program in Mesa where they had ambulances staffed with mid-level providers that would be responding out for mental health emergencies and for like relatively low triaged or low acuity triage calls. I know that they had a great deal of success with the mental health unit, particularly. The other one didn't make up any money and ended up closing out, but the mental health one in particular ended up persisting beyond the grant life. So I am thinking one of the things that I could possibly do to help out here is I could reach out to Mesa Fire, some of the contacts that I have with them, and just kind of see if I can touch base with somebody in particular who is kind of heading that aspect. And then I could come back to the group with at least some ideas of what their thoughts on the program were, how they address the, treat and refer aspect of patient care for mental health crisis. Would that be useful, do you think?
I think having you said that, I think one thing I hamstring myself is I only use Southern Arizona as a model. And so maybe I missed out on somebody who actually can. Tracy, you were saying something?
I was just saying I would love that. I'm a mid-level provider and see kids in the ED. And so we clear a lot. We do a lot of this. And so could we start that a step before they get to us? And it sounds like they've done that successfully in the past.
Yeah, it was great whenever it was going on. I don't know that it's in practice right now because I'm at Banner Desert. So, I work pretty close. I base Mesa Fire. I reached out to Ryan to ask if they still do that. They told us whenever they had it in effect that they were sending maybe 50 to 80 patients a month.
Wow.
Maybe not a month. That might have been a year to the behavioral health. It was probably a year.
Wow, that's quite a bit.
It just feels like it's a lot. But it worked out pretty well. They had behavioral health professionals on the ambulances, and then they were able to take them directly to the places. It was nice when it was going on. I don't think they have it anymore.
Okay, all right.
And that was largely funded by a grant?
Yeah, and originally they had a big grant where they were doing that, and they had the PA on one of the vehicles who would go out and do low-level medical calls, and then they had 2 of the behavioral health vehicles. And then the grant money, of course, was all gone. So
Yeah, that sounds right where we're at. And I'm sorry, Mr. Was it Coy?
Yeah, Coy's. Yeah, and I don't know how long. And I hate to interrupt the conversation currently, but I don't know how long we have Coy.
Exactly.
So
I want to get to him.
Coy just joined us, and it almost looks like he's in the rig right now. I don't know if he's at the station now or. But Coy, if you can hear me, this is a subgroup of the PACES committee. Oh, he just left.
Oh.
Right.
Darn
Well,
it.
hopefully he'll join us again. And then I'll introduce him, and we can kind of pop some questions at him. So
Sure.
um,
Sure. So, but in any case, Tyler, anybody that you can rustle up in terms of networking, and Dr. Woolridge, Coy sounds like a goal. This is the goal. We're meeting the goal here by drawing together a network, and that may be some of the incipient steps is to get people who know the information. But there he is. Go ahead.
Hi, Coy. Can you hear us? Okay. Oh, we can't hear you.
Yes, I can hear you. Sorry about technical difficulty.
Yeah, hey, Coy. I don't know how long we have you, but we needed some. We just run out of time. So the group you see with us now, we're a subgroup of the Pediatric Advisory Committee for EMS, the Department of Health, and this is a behavioral health brainstorming session to see what the advisory committee can work on to better understand, but to create some development in better behavioral health processing pre-hospital.
Okay.
One of the things that we're struggling with is what freedoms do EMS agencies have when it comes to assessment in the field and transport, whether or not they can transport to behavioral health. The understanding we have currently is that no. Do they have to go to the ED, or could there be an assessment in the field, de-escalation, that may not necessarily result in an ED transport? I understand from you that transport to behavioral health facilities was a possibility, and that's where we wanted to pick your brain.
Sure, absolutely. So I'll preface it with the fact that this is a highly dynamic topic and a series of information, actions, etc., and also variant by region in regards to resources, as well as the medical direction and the agencies that are involved in regards to it. With that being said, so in the Tucson area here, so we do have some capability to defer something that is a behavioral health event and somebody who is in crisis, and refer them over to the CRC and have them picked up and taken over, and or law enforcement sometimes takes them over. The assessment is that they typically don't require the ER at that point, so therefore we don't get involved in the transport. The reason why I preface my initial statement with it depends on where you're at, is there are places that are looking at trying to look at alternative destinations. So within the EM field, it's highly prevalent across the nation as well in regards to looking at how to take the patient to the most appropriate center right off the bat. Arizona, although I can't speak necessarily for all the particular regions since I'm not in them, I don't know if any of them have any agreements with AZDHS to deviate from going directly to the emergency room. As I indicated, like down here in Tucson, we do have agreements to where we can basically say, hey, we're not going to use our resources. We're going to basically assess this patient. We determine they don't need to go to the emergency room, so then we're going to utilize another resource to get them over to the ERC for evaluation. We also do transport to another level 1 assessment center, which is run by Community Bridges down here in Tucson as well.
So Coy, so that method of transport, so you're assessing in the field, determining there's not a medical need. Is it technically a treat and refer, or is it just a non-transport? And then question after that is, who actually does that transport? Is it the guardian who takes them, or is it law enforcement, or are there other agencies who do that?
Could be any of the above. So I'll answer your first part first. So how it gets documented is if you're really getting to the nitty gritty of what's reported in the national EMS database system, I think it gets reported as a treat and release. So, but there is the reality is it's more of a treat and release method, and it probably just depends on who's looking at it and how they choose to classify it. Your question in regards to who takes them. Predominantly, we try to get the behavioral health resources in town we utilize them. So either CBI or the crisis team. Sometimes we do leverage law enforcement if they're willing to. We never, constrain them to it. It's entirely based off of their comfort level, whether they want to or not. And then obviously within a case dependency, if the patient's stable enough and it's appropriate for them to go with, their guardian, then yeah, we'll send them over that way as well.
Do
Are
you find
you refusing the patients? Like, are you performing a refusal in the field to facilitate that process, Coy?
On our end, just from our agency, we'll have them sign a refusal form.
Got it.
But the language is more or less just to the frame of, hey, I don't want transport to an emergency room. That's firmly what's embedded in there.
Okay.
The greatest mechanism, probably not. It's probably more or less in use just from a historical aspect.
Okay. All right. Sorry, Dr. Ward, you were asking a question. I cut you off.
No, yeah, and that was a good. I was probably going to ask the same question. So Coy, anecdotally, because you probably don't have downstream data, but how often do you treat and release? They wind up getting to the behavioral health facility, and then the caregivers there ultimately do want medical clearance and then transport to the ED? Or do you think that you guys are pretty accurate and they wind up staying at the behavioral health facility, not getting bounced onward?
Intuitively, I think we do a pretty good job. But that's obviously just a gut instinct. Having my background, so knowing both within EMS as well as the fact that I've worked within, South Campus as administration, the numbers that we had coming from the CRC over to the ER for medical evaluation were not overly high. And if I look back and look and said, hey, you came in via EMS, and then bam, all of a sudden they're getting turned around and brought over to us to the hospital, I don't think the numbers were super high.
I don't want to monopolize. I don't want to monopolize your Coy. If you guys have questions, Coy, if you had to compare the adult population versus minors, do you think the treat and release concept is a more viable in light of there being a guardian present, or do you think it's less viable because of the nature of the vulnerable population of being a minor?
If I was to look at it, I think a lot of times as to releasing them back to the guardian is a potential setup for more difficulty. And it's the reason, my rationale for this is a lot of times the reason why we get called is because the provider or the guardian is at the end of their ropes. So they've utilized whatever resources, et cetera, that they can. And so inevitably, I don't think that's why I said it's probably one of the last resorts, because inevitably however we came in the picture, we're there because they weren't able to handle or address the crisis or de-escalate. So we recognize that, and we offer them the chance when appropriate to take the child over there. We don't want to use frivolously utilize system resources for something that's appropriate if they could be transported by them. But sometimes we recognize it's very stressful for the guardian or the caregiver as well too, and so therefore we utilize a transport resource to get them over there. That probably wasn't helpful.
No, it's reality, right? So Coy, if you were king for a day and you're going to solve the behavioral health ED transports, the stagnation of the behavioral health patient in the ED, where would be your low hanging fruit? Is it limiting transports, or is it improving assessment in the field, or is it really on the ED and that they have to figure out how to do a more rapid clearance and identify more beds in the community?
No, I think it's probably breaking down silos to where agencies and entities look at direct pathways and are in agreement in regards to those being the rules of engagement. And a lot of that is, it's not super, like, I wouldn't call it complicated. I mean, it's not like trying to figure out, some, astrophysics equation or something, but it is complex because it has a multitude and layers of entities and regulations and, rules, policies that are embedded in it. So in order to make all those mesh and work together, that's what makes it complex. But I really think that even though it's not a super low hanging thing, it's probably the element that would help the best, so that we could do direct transports over there. AZDHS was, a lot of the rules and regulations were written decades ago. So amending those to where EMS can transport to alternative destinations, having facilities, behavioral health facilities, okay with the fact that they're going to get somebody that hasn't gone through the emergency department. So I think those are the things that'll really sustain and improve the system.
From the group, any questions? Other questions for Coy? Coy, we really appreciate you taking out time. I don't know what we're keeping you from, but thank you.
Don't want to know.
Okay.
It's a behavioral health crisis, so but we're in a holding pattern at the moment.
Gotcha. Any other questions from the group for Coy before we lose him?
Thank you, Coy.
All right, take care.
Well, Coy, I had one other question for you.
Yes, sir.
Would you be willing to join our behavioral health work group?
I would love to.
Okay.
All right.
All right.
We'll bring you in on the emails.
Good.
Right.
Yeah, you'll be a great resource. So I'll plug you together with Adam so we can add you to the group.
Okay.
Awesome.
Thanks, folks. Have
Thanks,
a good day.
Coy. Appreciate
Thanks.
you too.
Appreciate it.
I think Coy, it's an organic. Let's see. It's the most natural solution. If you can just look up if we could give a paramedic an administrative order that gave that person the power to go straight to behavioral health, that's the answer. But he's right. It's just cloaked in layers of agencies, and so it is so far beyond me to try and figure out how to do that. But that would be the stroke of a pen style answer. I don't know. What do you guys think? The best we could do for now is, well, like you were saying, maybe develop maybe some awareness. Maybe we can start by increasing awareness of these things, of these resources. Because one of the other comments one of the medics I interviewed made was other guys in the department don't know that some of these resources are available, even as is the civilian assistance program, for example, that new medics aren't taught about that in school. And so they basically have to come across that in the field to realize it's a tool. And so maybe that's a place to start. But of course, I would love to just change, I don't know, legislation so we could just have a new administrative order.
And I was just looking at the CARES, which is the Central Arizona Regional EMS Guidelines, and it doesn't really even address anything behavioral health other than, the person in crisis. Doesn't list, I mean, it'd be nice to list behavioral health facilities where they could possibly take patients, because they list, all the hospitals and the perinatal centers and all that kind of stuff, but it doesn't even address that. So they don't know what they don't know.
Mm-hmm.
Yeah, this is it. And this is one of the major administrative guidelines that a lot of agencies in Southern Arizona use. And we've already looked at guidelines that are similar, and they're bare bones. There's nothing there. There's no resources there. There's no links. There's no nothing. There's no de-escalation. It is chemical restraint, physical restraint. If you have to take them, take them to the hospital. That's it. There's nothing. There's nothing special about it. It doesn't help anybody. It doesn't help the system for sure the way it is now.
What I could do is figure out what medical clearance is, like what is that definition and who is able to do those things.
Sure. Yeah. Absolutely.
Like, do you have to have an ED physician do that, or who are all of the people that would be able to perform that task?
Mm-hmm.
And that probably depends on the location of the patient. Of course, if they're in the hospital, it's going to be the physician or the nurse practitioner. Yeah. But if they're out in the field, they can always call for medical direction.
And that's more what I'm looking into, like in the field, who would be able to do that? What is required in order to get medical clearance? Because I don't know that. And so that would be helpful.
Okay. It sounds like we're still in need of a greater network of people that that can contribute a small piece of knowledge to this. And so with respect to the agenda, I don't know how much it should change in terms of that. I think we should still continue to bring people in. I think COI was a fantastic resource. It didn't even occur to me to ask the paramedics I was interviewing to sit in on this meeting. So I could ask, you know what I'm saying? So I could ask that we could do that too. Is there any other homework? So, I mean, Tracy, it's a good idea. Maybe we should look at what a technical medical clearance truly means in the eyes of the law, if you will. I don't know who would be, and a greater network, and perhaps begin to refine that stack of slides that I had it's just introductory pre-hospital behavioral health emergency stuff. So maybe we can kind of push things along, but it still doesn't feel like we have a nail to hit.
It could be nice to talk to different people in the EMS world to see, what do you guys need? Where do you feel like you don't know what to do? From the people that you've already talked to, if we could have a few of them, that way we could ask questions and hear from them directly. And that might give us a more definitive direction in what to offer.
Okay. All right. So it sounds like we still need a network.
Yeah. I mean, common practice is to create a stakeholders group, and you get representative of all the stakeholders. And right now, we have really no one from the REBA, the Regional Behavioral Health side. So if we could get a REBA member or even an administrator from the hospital-based system, and that's our stakeholders group to create kind of, a strategy moving forward. As an educator, knowledge is power. So creating that toolkit for the EMS agency of how more accurately to go through these things would be, I think, would be a way for PACEs to move forward. And that knowledge in the field might more accurately decide, transport versus alternative destinations versus de-escalation. But yes, I'm in agreement. We need to broaden out our stakeholder group.
Okay. So the homework will remain the same group?
I'm sorry, you broke up, Adam, say again?
I said, so the homework will generally remain the same, but is there anybody in any positions that like you were saying, a specific person, like somebody from REBA, and then, I mean, maybe a EMS agency, a larger EMS agency's EMS captain, maybe they would have something to say about it. I don't know.
I can invite Mesa, somebody from Mesa.
Sure.
Also, I'll ask Tempe Fire, because they have a PAS program, Patient Advocate Service program, that is funded. I don't know what they do with behavioral health patients with that, but I'll find out more from them.
Yeah, thanks for that, Mickey. We, doing my research, some of the larger, some of the agencies with the bigger budget have these small little, I don't want to scale them down in terms of importance, but they have smaller teams that do just that. And it seems like a lot of the agencies have these one-off little built-in entities that can deal with sort of a catch-all that isn't exactly 911. And so maybe we can pull those together. Maybe somebody in one of those groups can say, this is what we see and this is what we do. So maybe a multi-view from above and below. And be appreciated. Okay. Anybody else have any other ideas? I mean, I think we have a little bit of direction. I'll follow this up with some agenda notes and the recording and what we find, so we can all, and then again, I'll share the behavioral health, what am I calling it? Just like a folder for all of us. I've shared that link before, but I'll put it out there again after this. And whatever you find and whatever names you can find, just drop documents in there. It doesn't have to be official. It doesn't have to just resources, stack them up in there, and we'll have something to go off of. But otherwise, I think we've gotten something done, unless anybody has anything else. All right, Tyler, we know you're busy. We know, I mean, everybody, you all look like you're actually at work, and I kind of feel silly here, but that's okay. Jansen, I blurred my background too, but I didn't turn it on this setting, and so I'm a little off guard. But anyway, okay. If anybody doesn't have anything else, Dr. Woolridge, would you like to dismiss the meeting? I'm not sure.
Yeah, well, I don't. Yeah,
Parliamentary procedure.
I think the work groups are more informal. So, yeah, good discussion. I may not feel like it, but I think we're gaining traction. And we keep broadening our stakeholders group, and I think we have the chance of making a good product, and or at least we're shaking the trees and trying to get some of the right things decided on. So I appreciate that. So.
Okay. I'll do the same thing where sorry, Doctor. I'll put out a doodle poll, and we'll set up our next meeting for, a couple months from now as usual. Okay, guys.
Okay. Thanks, everybody.
Thanks, guys. Appreciate it. Have a good week. Thanks, Julia.